Wait a minute.
She's playing with Windows 7 on her new computer. I think she wants to talk to you.
Windows 8 fixing to come out too, so you.
Oh, Lord, I haven't got on to this one.
That's right.
Dick, you been doing well?
Doing well, sir. Thank you.
You didn't do it?
It should be 120, 23 minutes at the most. Okay. No, we're good. We're gonna hit the highlights and then.
When this is paused, what happens when it's paused is it'll turn itself off. You just hit the middle button to unpause it, when you pause it, hit the red button.
To pause and unpause.
July 27, 2012, special meeting of the area board will begin at 9:30.
Hello, Mike. How you doing? Been a while.
I guess that doesn't unpause.
Growing
I
smarter.
think I would know this.
Yeah.
Wish I was.
This hanging with Walter makes you smarter. You know what I'm saying?
Yeah, right.
Hey, girl.
Hello, Mr. Rowe.
Joey,
Yes.
what's the name of the alternate coordinator?
Dawn Cotton.
In your ballpark.
Dawn Cotton.
I'm talking.
July 27, 2012, special meeting of the area board. Meeting will begin at 9:30. That's what I would say. Yeah, just hit that button again. Okay. Just don't hit it too far. Okay? Anywhere until I get it. Yeah. Sure.
Steve, I know it's 4 more. Me and Tracy, Joe and Steve.
They may have tried to cut through town in the road.
I'm right out here. He's gonna be,
So good. Yeah. Yes. Yes, I will.
No, I'm going to plan this paper to stand on so I can do this. To help make it easier.
Never seen so many people here. Really? 6, 7, 8.
What's his name said he was gonna call him? Rutherford.
Carl Clafford said he would. Alan said he would. Maggie Faulkner said she would. Mandy said she was coming. All right. Okay. That's 9. That's 1, 2, 3, 4. That's 5 counties too.
Steve, Connie coming?
Sharon speaks when she gets up there. She needs me to hand the paper and it's going to be a long one. It's on. Yeah, we do actually. He's on 76. He's on 76. I put the fan on. You wanted me to go get him? You want me to go get him? Oh, I didn't see that. There's one behind her.
Good morning.
Good morning, Maggie.
Nancy from CFAC.
Nancy from CFAC.
It won't go lower than 72.
Carl, is that? Carl, you on? All right. Vic, we got Carl on. Any other? Yeah, we can hear you. Any other board members on?
Maggie Faulkner is on.
Maggie Faulkner.
Yeah. Their names on both of them.
Nobody wants to sit there.
I'll sit next to
Let's put it back here, buddy. You can handle it, Ryan.
How are you today?
How are you?
That alone is trying to process that. Make sure they can understand.
Yeah, this is you.
Folks, I'm gonna go ahead and call us to order a special meeting of the Area Board of Western Highlands. This July 27th, 2012. Thanks to board members, staff, and those in our audience for being here today, supporting this process. I wanted to say first that to the board that we need to elect and designate an alternate clerk for the board meeting today. It is likely that Ms. Huertas will have to leave at some point in the middle of the meeting. The staff member that's been identified that can substitute in at that point is Dawn Cotton. So at this point, I'll entertain a motion to do that.
So moved. Second.
All right. Any further discussion? All in favor?
Aye.
Any opposed?
Aye.
Okay, thank you very much. Going to public comments, the next item on our agenda. Mr. Rice.
Thank you, Mr. Chairman.
Well, if you want to crowd out, talk about money. Whether we're in a hole or not, it's all about money. One thing I'd like to say to this board is I appreciate all the work Kendra's done to try to preserve services and try to help services. You didn't have it from the beginning. If you doubt it, I've got videotape of every meeting, and we can go back and look at those meetings and tell exactly what we did. The minutes don't always reflect that. So there's some broad statements I'd like to make here, and I think they fit right into where we're at today. I don't think this problem today that we're sitting here for is about Western Highland Network. I think it's with the mental health reform that started in 2001 that was screwed and flawed from the beginning. And some of the folks know that that's sitting in this audience. And the other problem I think we've got is a bigger problem. It's called PBH modeling. This state should recognize that we cannot follow PBH modeling because we're not like PBH, that's for sure. Western Highlands has provided services from January, and they have really tried hard here. The board has tried hard, everybody tried hard. And I think we need some better cooperation at the state level. And they might be doing a pretty good job, but I think we need to separate PBH from Western Highlands and let us be our own identity. Bigger is not better. The state is trying to reduce us to smaller LMEs, numbers of LMEs, but make us bigger. And in my opinion, we're going to be screwed all the way around on service. The last item I want to leave you with is the one that I deal mostly with, and that's school-age kids. And a whole lot of work with DSS, and juvenile justice, and the schools. We're focusing on big issues here, but we're not focused on the primary issues. We're not doing anything with prevention. I'm talking about the state isn't, I'm sorry. The state isn't looking at prevention. We're going to have a backlog that's going to hit us on down the road, and we're not sitting here today for any small matter, but we're going to be in the future sitting here for a much larger matter if we continue down the road that we're going on now. Thank you.
Thank you, Mr. Rice. And I apologize, I am having trouble discerning what that second sign-up person is. She knows who she is.
You look important, they can't read your signature.
Okay, I remember.
I'm Janet Price Farrell. I've talked to you occasionally before. Parent of a son with DD and work a lot in the DD and the childhood community. With concerns from the report, the budget cuts on how this is going to affect the DD community. We seem to be the last one on the list, and the last one to get the services and the first one to be cut. But talking to the board and looking at the report from the Mercer report, every single one of you as a board member knows what it takes to run an organization, and especially the county managers. You know that it takes, it involves leadership, up-to-date current data that you can get at the push of the button when you ask for it, not 3 or 4 or 6 months later. And it takes an organizational plan that is designed to work the way it is supposed to work. Western Highlands is now a managed care organization. That means you're here to manage the people and not just the money. So I'm asking you to continue to follow down that road. Thanks.
Thank you. The next speaker signed up is Jean Alvarez.
Actually, I can probably just stand right here, if that's okay.
That's okay.
I just really, I saw Tracy walk in and I was just like, oh, there's Tracy. I'm a parent advocate from the Autism Society of North Carolina, and I'm a parent of a 26-year-old young man who has autism and IDD. He has innovations through Smokey, so we are going through this big transition right now. And it has been extremely stressful, and I talk to parents every day who are either struggling with not being able to get services, or they're struggling with trying to understand all these changes. And I almost applauded Janet when she said DD folks are always the last one to get services and the first ones to experience those cuts. But I'm here to represent the Autism Society and take information back, but I'm there first for the families, but my heart's breaking right now for some of the wonderful dedicated professionals in the field that are extremely overwhelmed, but still trying to meet the needs of their families. And I just fear more cuts are going to be so difficult to manage for families and professionals. So, but thank you all very much. Thank you for serving on this board, and thank you for grappling with some really complex issues. So, I'm so happy to see you.
Thank you, Ms. Alvarez. And then I Final speaker I have is Jane Lindsay. Sorry.
I've never been before a board, spoken to a committee before, but I've spoken to a lot of people at the local, state level. I am the guardian of a 21-year-old IDD consumer who's been in the CAP program since she was 10 months old. I've watched CAP go through trend, the changes, the different waivers, the rewriting of waivers. I know that probably the board is here today to talk about money and talk about how the deficit that you're in is going to have to change. I fought against the area authorities. I have to say I'm happy that Western Highlands is a managed care entity right now. I think that it needs to be local. I think it needs to give people the access to come and talk with you people, talk with the directors, talk with the people they need. But what I see is that we're losing our psychiatrists, we're losing our staff that we need. There's budget cuts that are coming. And I fought for years for direct care staff, because without direct care staff, you don't have a CAP IDD program. You can have all of the service providers in the world, but unless they pay their staff, and the staff has been cut time after time after time as the budget cuts have come along. And years ago, I made this picture that was hanging in Hendersonville, a Pizza Hut looking for a service delivery person paying $12 an hour. I can guarantee you that the providers are not paying their direct care staff $12 an hour. I know direct care staff recently, one that worked for 10 years and loved her job. She left her job to go to work for a cleaning service because she got paid more for cleaning houses than she got paid for taking care of the most vulnerable people that you're mandated to protect and meet their health and safety. And one of the things that I'm here today to say is a living wage in this area is $11.35 an hour. I can guarantee you that our CAP direct care staff are not getting that money. Look at other ways to recoup the money you need. Look at overprescribing of services. Look at misuse of funds. Look at the billing issues. Look at the Medicaid fraud that's going on. Don't look at cutting staff salaries again, because I know I'm not real popular with a lot of providers, but all the cuts that have been made, I've never known a queue that have gotten their salaries cut. I've never known management staff that have taken cuts in salary. I don't know HR people that are taking cuts in salary. It gets passed along to the direct care. And quite honestly, my child is more valuable than a Pizza Hut delivery person or a person that goes to clean a house. Thank you.
Thank you. Moving on to provider comments, we have one, Ms. Lori Bone.
I'm Lori Beam, I'm the Assistant Director for the Arc North Carolina here in this region. Known for many things, but not being a good speaker, so I'm really nervous. I believe the per member per month amount was set too low, that Western Highlands was set up for financial failure from the very beginning. I used to brag to my counterparts across the state when we would have our meetings about how good Western Highlands was at budgeting their money, because we didn't encounter here the elimination of state-funded services that was felt in some other parts of the state. I find it disheartening that what was the best financial agency, in my opinion, LME, is now the worst, and I think it's because of this per member per month amount. If you're looking at a $500,000 shortfall a month, that comes to $6 million annually. If DD is 75 to 80% of the budget, that's $4.8 million that will come out of the IDB budget this year. That is affecting the neediest people in Western Highlands. They will be the ones to pay for the ultimate price for this mess that is currently going on. The provider agencies are struggling to keep up with the added responsibilities that they have. Obviously, we're not getting more money, and you're talking about cutting more of our money off the top. We have a very difficult time finding quality staff or any staff at all that will work for the wages that you can pay.
Thank you, ma'am. That's all of those that have signed up to speak. So we'll move on to item 5 on the agenda related to information and reports about the Medicaid waiver.
Morning, I got elected to go first. I'm a little disheveled this morning. My wife has a booth at Belshare, so we're up at 7 o'clock. There's a lot of manual labor involved.
Good to see you, Carl.
I'm still trying to cool down. Just want to begin our discussion with how the PM worked. Last fall, we attended several meetings in Raleigh. DMA and Mercer had an actuarial team, and they did a comprehensive study of what our PM should be, and it was based on the most complete and comprehensive data they had available at that time, which was 2009 data. So our PM was based on 2009 paid claims, and their data, we ran the same data, and our figures kind of matched pretty closely what they had developed as well. Once we got their figures, we put together a local group of individuals to analyze the PM analysis. That group consisted of some board members, some financial folks from our local hospitals, a couple of community members, and they looked at the PM as well, and kind of thought it was kind of the best guess we could come up with given the data.
Charlie, I hate to interrupt it. Does everybody know what PM is?
I don't.
Would it be helpful to just tell people?
Sure. PM is a calculation that is based on per member per month. They take the number of people who are eligible for Medicaid in our area. It's roughly 70,000 people, 75,000 people, and then pay us a certain amount per individual. I don't even know what the number is, but they pay us that amount of money. And that's the money we have available to deliver services to the folks that need behavioral health services in our area. So it's PM per member per month. They pay us so much per individual that has Medicaid every month. The aggregate amount is right close to $10 million. So we were concerned a little bit that they took this amount that.
Charlie, what is the exact amount?
Sharon can probably rattle it off. I don't know.
The 167.57, but that also includes our admin and our risk reserve. So 14% of the 167.57 per month, is reduced. So 86% of that.
In dollars. In dollars.
Oh, are you looking for?
It's about 9.5, isn't it?
It's about, it's been going up a little bit, but it looks like it's rounding off with around 9.998 average. It started out in January, it was 9.4, February 9.6, 9.6 in March, 9.7 in April. But now it has leveled out to about 9.8.
How about figuring, let us know the exact number, if you don't mind?
It's on.
No, I'm talking about
the individual per member per
individual's
month.
what he's saying.
Minus the
not
14%.
total. You know what the total is.
This is for services. This is
The individual per member per month, 86% of the number that you gave.
When you
That's
fill out
what-
the admin and
that's what this number is.
What do you
Per
say?
member per.
That's what they're asking.
Okay, this number is the service dollar amount per member per month.
But they
This
want
does not
dollar,
include.
individual.
Person.
Individual.
How many people?
How many?
Divide it by that,
Okay.
the number of people.
Okay, I can do that.
Troy, just before we leave that point, you used both the term eligible for Medicaid and receiving Medicaid, which are very different. Which is
Correct.
it based on?
It's
Eligible
Based on
or
eligible.
receiving? It's eligible.
Now, is that people who have been determined eligible by DSS?
Yes, people who are
Yes.
enrolled in Medicaid.
It's enrolled. That's
Enrolled.
really different.
Enrolled in
Enrolled,
Medicaid.
not eligible.
And that's why it's going up each month because more folks in the last few months are enrolled, correct?
Then you've got some retroactivity that causes that to change.
So, the other thing is, you know, once they arrived at in order to arrive at the figure, they reduced it by 30%. So they figured that we could save, 30% in terms of by managing our budget, that we could save 30% of our funds. So.
One question, you said it's going up 9.4, 9.6, 9.7, 9.8, now 9.998. Is that due to more people being enrolled in Medicaid?
That's part of it,
So
but
the
it's
rate's
also
not
in
increasing, it's
retro,
the
people
number
getting.
of people.
Yes, yes,
So there is an adjustment for the increase in people.
yes. More
Okay.
people, you get more money.
Okay.
Thank you, Charles.
Charlie, one other question that I've got, please. Seems like I remember we agreed with that PM.
Right.
Okay, thank you.
My part here is a little simpler, and that is how we implement it. The way we tried to, the emphasis that we had during implementation. My name is Don Herring, for those of you I haven't met yet, I'm Director of Medicaid Operations here and also Contract Manager with the state. The initial focus of what we focused on was how we were going to assure that consumers got services. So we had to do a lot of things with authorizing and honoring the auth that came from Value Options. And we had to make sure that everybody had a contract. We made sure everybody was credentialed appropriately. We made sure that everybody, so that they could get paid. And then we made sure that we could accept the claims and pay the claims that came in. But more than anything else, we had to assure that the consumers were going to get the services and supports that they needed. So in order to do that, that's what our focus was. And then on top of that was to maintain provider stability. As you know, all of you know this, have been here for the last 5 years. We've had a lot of providers who've left the network. We had to make sure that the providers were going to maintain stability in the network. And then was develop the management report systems. The only area that we've had problems in the authorization piece is with the facilities, which is called DSOF at the state level at the division. And we told them that as of April 1st that we were going to really tighten up and say that if we don't have an authorization, we're not going to pay you. And I talked to Tara, and Tara said, no, you're going to have to pay them. Tara Larson at the department. So we have had some payments without authorizations to the state facilities, but those are the only ones that we have allowed to get by. And we are in discussions with the department on how we're going to tighten that up as well. I have a list here. I'm not going to go through this, but just to show you, there's 5 pages of pretty small type of meetings that we've had with the department regarding implementation since we've started this. So I can have that available if everybody wants to look at it. Thank you.
Thank you, Don.
Chairman?
I'll send you my contract.
I'm passing out some blank paper. Just grab one sheet, and I'm hoping it's going to help you easily read spreadsheets that I have. I have 4 Excel spreadsheets. I have the first one that is A. It's shown as A. What this report represents are our paid claims, and it's by date of service and it's by the month that it's paid. So what were we looking at and how were we looking at it since January 1? If you would take your blank piece of paper and cover everything except that first column that says January. What this represents.
It's your request. Can you speak up and can you again refer to the sheet of paper you're talking about so I can pull it up on my computer?
Okay, this one is identified as A, and it's called the Medicaid paid claims, paid month, and date of service. So if you've got everything covered except for that first column in January, what that represents is those are claims that were paid in January with a January date of service. Okay? And it was $1.4 million. So at the end of January, the first week of February, I'm going, okay, we got $9.5 million, we're doing pretty good. Scoot that over to February. We processed claims in February of $7.1 million. I still got $9.5 million. I'm thinking, okay, we're still doing okay. Out of that $7.1 million, $5.3 million were with a January date of service because they're in the row that is January date of service. And $1.8 million was February date of service. I'm still not too concerned. I've got $8 million accrued on the financial statements. I'm thinking it's looking okay. Scoot on over to March. Now you have to understand, you know, this data is coming to me like the first week after the end of the month. So in March, it's 11.2 million. It's up. I'm like, okay, that was for, you know, paying out some of that $9.5 million from January and February. It's time, you know, we're getting closer to the 90-day timely filing limit. But I also did a calculation, and if you look at the color code yellow, those were all dates of service in January. So I wanted to add those together. How much of our January money have we actually spent? It was $8.8 million. So at the end of March, I'm still going, well, okay, we're not supposed to be having a big surplus of money, so, you know, it's looking a little tight. But I'm still thinking we're okay. If you scoot on over one more column and reveal April, the amount paid out in April is $9 million, okay? That's not too bad. And then if I look at the February row, that's colored in purple, and add that together, if you look February, March, and April, that's $9.2 million. I'm still within our PMP and for services, so, you know, it's not that bad, and at this point in time, I don't know what is out there, what the providers have done that they've not billed us for. I mean, we don't have any of that history as far as knowing what they're doing. Okay, so then along comes May. Look at that jump. At the end of May, I'm realizing we just paid out in the month of May $14 million. I'm like, uh-oh. I'm looking, and so this was like the first week of June. And if you look at the green color coding for March, April, and May for the 3 months, and I'm looking at for dates of service in March, I'm looking at 10.4 million. And all of a sudden, I'm like, whoa, we're in trouble.
When was that?
Huh?
When was that you said, whoa, we're in trouble?
It was the first week of June.
First week of June. When did you send the first quarter financial reports to the state?
It was in the middle of May.
May 24?
Uh-huh.
Did
So
those reports show that we were in trouble, Sharon?
those reports would have shown the information through January, February, March.
30.221368 million.
Mhm.
Okay. So we were in trouble on May the 24th.
No, the report for that, the first quarter reports, those were attachment W reports. Those were the financial reports which represented activity for the first 3 months. And so the financial activity for the first 3 months were what were reported in that first quarter. Note, and they matched the financial statements that were presented to this board. So at the first week of June, I immediately contacted, my IT director, and I said, I need some reports. I need to see a detail of every single month during the calendar year 2011. I need those services filtered to only be the services that we are currently paying for in our waiver world. So the report number B was prepared for me. This is also, the only reason it's color coded so you can see the lines or the rows easily. When I started studying this report from a grand total basis, because I had been looking at this report from a trending per service category basis, and I wasn't seeing giant fluctuations from month to month to month, but when I got the totals, and if you look at the moving average, the very last row on this chart, this is showing a moving average of payments during every calendar year, every month in 2011. And you have to understand, this data didn't get mature until about the time that I asked for it, because providers had 365 days to bill. So the paid claims data was just still coming into us at that point. But this shows that we were spending immediately prior to the waiver 11.2 per month on average with Medicaid dollars. So at that point in time, in running some reports, and I started running a lot of different reports, I would say that C and D you can look at. I wanted to go back and say, where did this change happen? How did this change occur? So if you look on C, this is Medicaid paid claims for 2009, 10, and 11. What you might see if you look down about row 6, you look at PRTF, the service category of PRTF. In 2009, that's what our data book, that's what our PMPM was based on, was the numbers in 2009. But if you look at PRTF, in 2009, Medicaid paid out $7.9 million. In calendar year 2011, Medicaid paid out $12.1 million. And then if you come on down, which is a little, quite a bit more interesting, come down 5 more rows where it says number 8, MST, and IIHS, which stands for Intensive In-Home. MST is Multi-System Development. Okay. I think most people know what that is. Joe knows what that is.
But the grand totals are less.
Because community support. But just for that one category, as far as trending, our PMPM was based on $3.4 million, and in calendar year 2011, Medicaid paid out $11.3 million. And so, and what I've got in the pink box up beside it is, if our service income is averaged out to about 9.9 now, times 12 for annually, that's 118 million, compared to the 133 million for the 2 prior years. So that's expecting a 30% reduction in Medicaid services or payments, Medicaid payments. That's, to me, that's, pretty much of a hefty goal. We are running these reports actually weekly, sending them to DMA, sending them also to Mercer. The next,
when did we know the 30% cut? We knew that going in, didn't we?
I believe it was in the data book. The final is category of service. This is in 5 category of service, the grouping of the service of Western Highlands in our paid claims in our current fiscal year, January through June. And of course, it's not totally mature. You can tell June only has $3.3 million, but it's the data that we had when we ran this report. This report was for as of July 2nd. And what we have below it, we have the Medicaid paid claims for that same period a year ago. So that's comparative. So I just wanted to give you this information and open up for questions, whatever questions you have for me.
I probably, I'm not sure it's a question, but I think one of the places that I feel the most frustration is, I sent an email on May 30th that said, wow, suddenly this trend is very different, what's up? And the response was, it's about lag in provider billing, it's not a problem. You know, I sit in finance committee every month, and I didn't ever hear why. I went back and read all the finance minutes, and CEO reports and didn't hear why. So I guess I'm trying to figure out when you say June 1st, I knew we were in trouble.
It was the week,
Well, I sent an email May 30th and get a response 2 days after that basically says, no, you just don't understand the spreadsheet, we're okay. So I'm having trouble with when it hit, it really was a problem. Doesn't show up in the FY budget. The presentation that was made to the board to adopt the 13th budget. So I'm just trying to understand the timing. Because I think one of the focuses in Finance Committee has been relentless on projections and how do we really know these projections are dead on?
Exactly. And I totally agree with you. You know, that has been a focus of the Finance Committee. And you did ask repeatedly, how do you know what's out there that is not being billed? And I said it's difficult. I mean, we're working on getting our trending tools together. We're compiling the data, but I didn't know what had not been submitted to us in place.
I think a really important thing for us to know is what is the data, and I mean, we don't have to do it right now, but it has to be part of this plan. What is the data you don't have access to? You have to have access to for you to be able to make accurate projections.
Right. Well, if you look at this claims lag report.
Well, I am looking at it, but I'm also somebody who spent numerous hours in Finance Committee and numerous times have asked about this and have been told, we're fine. In fact, the projections that I go back and read are, the worst case scenario is we're running at a $1.8 million surplus.
That's why I was using the thing to cover. That's the data that I knew at the time. The projections of going forward. It's very difficult in startup of knowing what's out there. And I understand and I agree with you.
I don't challenge and have said, having been in a waiver environment, it's very difficult. But I think that's when it's the responsibility of staff to predict for boards those difficulties and talk about worst case scenarios. That was kind of the shocking part for me, is to read in the media something so vastly different than what I've been told every month and to my specific questions. So anyway, thank you.
Sharon, just to follow up on what Andy said, when did you really realize, I mean, can you give us a point of reference of when that was that this came up? Again, I'm just trying to relate it to when our board met. Can you tell me when it was?
It was toward the end of the following week.
Of what?
June. The first full week of June. June 1st was on a Friday. Then, you know, it was toward the end of that week when I received the
So June the 8th, this was prior to our board meeting, that you all knew that there was a problem and prior to our budget.
I would say this, that I recognized that it looked like that we were in trouble. I really, before I started crying wolf, that the skies are falling, I needed to be positive, and that's when I had IT work with me in creating these other spreadsheets so that I could nail down, and I mean, I couldn't just say, we're really in trouble and not know where or why or the trends leading up to that.
And Chair, may I ask, when was that?
Within days after that.
Now, you and I met on the 11th.
Well, it was after that I started getting those reports.
And everything was all right, but I had seen some of the stuff that Mr. Stone was talking about and was representing Bronson County, that was my question to you. And so I really just don't understand what went on. I don't understand how she had one thing and you had one thing, and of course you come up here at that meeting and Mr. Man went up here to this board to try to convince me that this was that, this was should, and that was all. But anyway, then after that, you and I met, so you convinced me everything was should. But then, you know, then I look in the paper and everything went soft overnight, so I don't understand. So go ahead.
Sharon, when was the state notified about this? At that point in time, did they come back prior to, while this was going on, while we were looking at these reports from the state, respond to the interaction with the state about the financial situation?
The interaction with the state occurred when I had all of the information that I felt 100% positive of the situation.
Is that the first quarter financial report that was sent to them on May 24th?
No, this was on June 27th when we were having our conference call with all of the division representatives as well as DMA.
But now this info that was sent to the state on May the 24th, it shows about $1.5 million loss in the first quarter. Is it not?
Which report is that?
It's the first quarter financial report that sent to the state May the 24th. $30,221,368. Arthur said this is the material sent on May 24th.
Right, this was the attachment of the reports.
That's accurate, because that's what generated my question, my email question on that day.
This was a claims processing report. I'm gonna have to look into this.
Okay.
I don't,
Just one more question. From the point that you, whatever point in June it was, felt like we were in trouble, and I know that wasn't something shared with Finance Committee, I just wonder, was there any notification to any other member of the board, like Finance Committee Chair or Board Chair at that point, at any point in June, when the rest of us weren't aware of it?
The first I knew we were in trouble was, I guess, or something was going on, was I got an email from Arthur saying, you might be hearing something about this, and it felt to me like I'd missed something, and I did miss the June board meeting, so I thought, well, maybe this was, you know, I was renewing my licenses and stuff, so maybe that's where some of this came out. But then I've talked to other folks, and it didn't come out then. And then the next day, I happened to be in Raleigh visiting a friend, and I picked up the News and Observer and saw her name mentioned, and that's when I went, oh, word, you know, something's going on here that we need to get on top of.
I had a staff person in a meeting with a staff person from Western Highlands who came back and told me just like the day before it hit the media.
Sharon, going back to A, I appreciate the detail that we're seeing today. I guess I'm trying to understand where we believe that we stand as of the end of June, you know, with the claims that have hit the system and with our PNP. So I see, it looks like a total of that 53 million by the end of June. But we think when all June claims are realized in subsequent months, that we will be in the hole.
The grand total is there. What I'm projecting for June 30, I'm looking at, we're gonna have a net loss of anywhere between 3.5 to 4 million. We are going to have a surplus in admin of about $2 million. Could be 2.1 million to cover those losses. We've also set aside $1.3 million in risk reserve. So I'm looking at, an overall shortfall of anywhere from $500,000 to $1 million after we have depleted all of the surplus and admin from Medicaid. You keep in mind, we've got 2 sets of books. So the surplus from Medicaid, the risk reserve, that has been set aside at $1.3 million. I'm still looking at an overall loss for services, probably $500,000 to $1 million.
That'll have to be pulled out of fund balance.
When you say the 3.5, is that for the year or just at that point in time up to June?
6 months.
And
Can you please speak up on those last points? We can't hear you on the phone.
What I'm projecting that we're going to be at June 30, I'm projecting.
You're right on the board.
I don't have it.
It's saying the clock.
There's one right.
I think that we are going to be in service dollars, that we're going to probably have a loss of approximately 3.5 to 4. That's my today's projection. Okay, so if we have a loss of 4 million. I've got 2 million, 2.1 million. I would say 2 million in admin surplus, and I think that that's fair.
And while you're writing that up, though, if this is first 6 months and a trend going forward, that admin surplus would not exist in the future because we've staffed up, and so that's
Yes, ma'am. That is
one-time
correct.
money. And that'd be
So those
equally,
savings are only good for 6 months. That's what you're
Correct.
pointing out, man?
and that'd be equally true for what we pull out of fund balance.
Right. Oh, yeah. And
Yes.
you mean the risk reserve?
Risk reserve.
Risk reserve. It's gone.
And
So
is
we
that the risk reserve that counties put restriction on when it could be spent, that it had to be built to a certain level in most of the resolutions?
It's not just the county, it's the state as well.
I know, but each of our counties, I believe, adopted something similar to that as well.
So Sharon, we could lose $1.5 million the first 6 months. We're set to lose 4 to 5 the second 6 months.
We are looking to, and obviously we're going to have a plan of correction in order to turn this around. One of the things that we have to do right now, because during the first 6 months, and when Mercer was here, they, in evaluating us, they did say that it was the appropriate thing that we needed to do. But we had a lot of problem with providers being able to bill. And specifically a couple of our really large providers that weren't able to bill. A lot of it had to do with moving from the 40-10 format to the 50-10 in billing, which is the national requirement, national standard. That was difficult for a lot of billers who were billing electronically. In addition to that, because there were a lot of clearinghouses that our providers had to work through clearinghouses, the clearinghouses would not work with us at all until they got their 50-10 system set up, because we were peanuts to them pretty much, and they were just getting their system. We've got those clearinghouses in place, so we made an accommodation to our providers that extended the 90-day timely filing requirement through July 31st. One of the things that we have to do, and that we have to be very, very hard on it, is to implement on August 1st, reinstate our 90-day timely filing requirement that's in the contract and stick to it. That is, and you're stuck between a rock and a hard place. I want the providers to get paid. We also need that information as timely as possible. But with some of our plans of corrective action, and we're also meeting with, I'm communicating with Mercer and DMA on a weekly basis, sending them this report weekly, talking about, and then asking about, what are we implementing. A lot of it, and we have beefed up our quality audit and review to where we will have to be recouping funds from providers where services were paid inappropriately. And making sure that all of the claims that were paid accurately. And those are the things that, some of the recommendations that we got and counseling that we got when Mercer and DMA were here on site for those 3 days. And we have other plans, and I think that Marcia will be speaking to some of those other plans. But no, I mean, we are going to have to be a managed care organization. Up at the 1.3 up?
About 5 for the next 6 months. 4.5 to 5.
Assuming you don't make any changes.
Yeah, right.
Well, and
You gotta do all these questions.
you gotta do it risk reserve, and even if the board agrees part of that's out of funding cuts, there's a cycle of notification and appeals, so it's not like that's gonna move off.
And,
Well, and let's keep in mind some of the community and provider comments too, that we have people out there who, we're talking about, as Jerry Rice reminds us every month, we're talking about dollars and cents, but when you get it down to the service level, you're talking about people's lives. So we really need to do this in a way that takes into account
yes,
the people who are, the people that we come here and meet about every month, which isn't us, or it isn't the dollars, or it isn't the state. It's about the consumers who are recipients of the services that we oversee.
yes.
And everybody may know this but me, but if the risk reserve funds are used, I assume that we are responsible for replacement of those funds. Those aren't just replenished perpetually.
Yeah, well, we are still getting 2% of our PMPM is for risk reserve. We continue to get that. I mean, and it runs around $220,000 a month.
We're supposed to build it up to 15%.
Yes.
But if we were in the position of needing to utilize those funds, I mean, can we really use them for that purpose? I mean, and then are we responsible for putting that as funds back into that risk reserve?
We're not actually gonna replenish the 2% if we take it away. We're gonna still get 2% each time.
We're just going to continue to
but we're
get
not gonna
2%
replenish
of
what we take
the
out
risk
of it.
reserve funds will just be, we will make a request to the department to use those risk reserve funds to cover the loss. And it's not, I'm not aware that it is a loan. I'm aware that that's what it's there for.
Yes. Steve, I wouldn't be that worried if we were just, if those funds would cover us and our administrative savings would cover us.
Sure, one last question. Did we know this shortfall was here before we adopted our previous budget for this year? Were we aware of it then, on the day we adopted this budget?
I was aware that we were in trouble, and at that point in time, I was still gathering the information, Charles.
Okay, but this is Carl. I want to follow up on that specific point. That's the part that's been bothering me through all of this. We met at the budget to review the budget on June 22nd, and absolutely none of this came out at that meeting.
This was, this was a special meeting of the board, and it was my understanding that the agenda could not be changed. Because I tried, I mean, I don't know.
Wait. Let me explain. We're facing over $3 million budget shortfall, and that issue couldn't be brought up as part of the upcoming budget discussions. I guess I'm unclear on that.
Carl, we may have to address some of that in closed session.
All right. Thank you.
I appreciate the question. And of course, thank you for the information, Sharon. Any more questions for Sharon? I want to clarify something that I said in response to Mandy's question about board member knowledge about information, because I really want to be very transparent today. to everyone about when information was shared. I do recall a conversation with Arthur after one of the June meetings. I honestly don't remember if it was the one where we had the public hearing or if it was the subsequent adoption of the budget. After one of those meetings, I had guidance from the board to follow up with Arthur about several issues. In the course of that conversation, somewhere in there, he injected a comment that they had a cost overrun or perceived they were in a cost overrun issue. And you may have thrown out the value of $500,000. I don't recall, Arthur. We finished talking about the topics at hand, and then I came back to that statement and I said, you know, you threw that out, the best that I recall, Arthur. I think I said something like, you threw that out very casually. I said, but that sounds like a big number to me. And I said, do you feel comfortable that that can be managed or handled or factored in and overcome? And at that time he said yes. So there was that flag of that mention of that.
And I appreciate that clarification. My question was more about, was there a call specific to, wow, we're running a $3 million, we might be hitting a $3 million deficit? Was my question to you and Nathan as either the finance chair or the board chair?
And I didn't get to answer my point to that is no, I had not been notified of it.
Okay, that's just me.
Artie, do you have a question? Okay. Hey, Marcia.
Hey, guys.
Thanks.
Good morning. Hopefully my presentation is going to be pretty brief. I wanted to make you aware in the clinical arena of 3 different things. Some of this, in number 3, you've heard from me before, so I won't spend a lot of time on that. But I want to remind the board that we had to honor value options and crossroads rollovers in authorization. One of the things that happened with that is we were given, and that was by contract, we were given spreadsheets of services that breached January 3rd, sometimes into December of the current year. For example, on the innovation side, people get plans per their birthday month, and so the ones that Crossroads approved later in the year carried over until the upcoming months of December, November, October, all the way to now. So we still have authorizations that somebody else reviewed and made decisions on in our system on the IDD side. The value options rollovers were also pushed through, and we're starting to tail off on those, so we're just now starting to review actual clinical services. So that was one issue that we did not anticipate, that we end up being encumbered with just the contractual rollover and not actually reviewing the services of all the rollovers. We got spreadsheets, no clinical information. The second thing is the transition from CAP to NC Innovations. Even though we did that initial transition to equal service as much as possible, it costs more on the innovation side. Because we had these authorizations that went out through December of 12, these services cost various 12. If you look at about a 12th of the population having a birthday in any month, then we were behind the 8 ball on the transition from CAP to innovations. The third thing is that now that we are reviewing clinical information, when I made my presentation to you before a few months ago, one of the things that we have found is lengthy duration of services that are designed to be short-term, such as intensive in-home. We have a cohort of intensive in-home that is 18 to 20 months old, that they've been getting that service consistently for that period. The service was designed to be a 5 or 6 month service. There are an inordinately large amount of these services that have gone on for years. Community support team, also designed to be a short-term service, has gone on for years. Day treatment, designed to be a short-term service, has gone on for years. SAIOP has a prescriptive amount of service, gone on for years. So what my clinical operations team is doing in that arena is attending treatment teams, being involved with providers to pull in the duration of service to a reasonable level. Either the service is not working and the consumer needs a higher level of care, or it's not being delivered well, So there's monitoring associated with some of what we're finding, but we're starting to look at these service lines that are going on for long duration. Second area of surprising findings that I talked to you about before was service stacking for outpatient service. And that's the use of one or more services that are intended to be a single comprehensive service. So that's stacking of things like level 3 residential with day treatment. So instead of a $300-ish, $325 a day service, it zooms up to $688 a day. We have hospital contracts that are not getting that much a day. Also the combination of assertive community treatment team with outpatient, when ACT is supposed to include a clinician. Then some of the more expensive combinations are intensive in-home day treatment, therapeutic foster care, and individual therapy. In some cases, $1,800 a day in claims. So in all those situations of service stacking, we're starting to send our staff in to do care management with providers, again, to try to pull that service back. I've hired 4 people who worked in other parts of the state in service provision agencies, and all 4 of them say that this never happens in their area. I'm talking about the Durham area, the Greensboro area, and the Charlotte area. That they do not service stack in those areas. They've never been allowed to. Somehow our culture got to be that we stack a lot of services. The last area that I talked a lot about is the use of residential care for kids. We've presented a study to DMA that we've done on our population of children in residential care, specifically in PRTF. Children who have conduct disorder only, 80% of them are getting worse in that level of care. And I gave you the example that started our concern where some of our children who have been traumatized by their history were getting hurt by conduct disorder kids in those venues. So we're starting again to be called into court and questioned about our opposition to recommendations to put kids in a service that makes them worse, where we can't get kids into the service who actually need the service. And interestingly, in our study, 78% of the kids who really do have psychiatric diagnoses get better, 78% of the time in PRTI, but they don't when it's combined with externalizing behaviors. So we're still pursuing that across a number of venues. The last area of concern that I talked to you about before and service area concerns is use of long-term residential care for children. We're just starting to look at those on a case-by-case basis. We've had extensive discussions with our county DSSs around some of the issues in that particular arena, and I think Angie Pittman and I are working closely together to get our teams together because they have one set of mandates, we have a different set of mandates. There's a lot of misunderstanding about the whole system of care initiative, which was a much more collaborative process where we could negotiate, they could negotiate. Under the waiver, we can't negotiate. We have to hold up the terms of our contract. So medical necessity has to be there. It's a shift in how we work as a community and as community partners. And so we're working aggressively in those areas. So in terms of problematic areas that probably led to some of these overruns, these are the 3 areas that I'm seeing from the clinical operations side. Questions?
Yeah. And a couple of things that I know about. I don't know that much about residential, but like SAIOP, as you said, is very prescriptive. So is what you're saying that value options didn't have the edits in place to, you have to do this exactly, this much service, this many times a week by the book?
The difference is value options had more of what the field calls a UR contract. We have a utilization management contract. UR contract is medical necessity there for that diagnosis, and if it is, the service is approved. With utilization, so the overrun is probably because somebody finished SAIOP, another request comes in because the consumer or the provider felt they needed more SAIOP, and this is the standard that was applied again. In utilization management, you look at this, but you also look at, is this the best service at this time, in this intensity, in this duration? So there's a difference in how you look at approving those services.
The other question on the service stacking, is that an issue where the edits weren't in place?
No, that's an issue where medical necessity on the UR side by Value Options said, yes, this diagnosis meets this medical necessity, it's EPSDT because it's a child, we can stack these services.
But the service definitions were very clear that this is a standalone service.
Yes, sir.
And there are a number of service definitions that say, basically, when you're getting this, you don't get this, this, and this. You're
Service
saying they
exclusion
were in
criteria.
there.
Exactly. But because all children's requests are considered to be APSDT, Value Options, I believe, did the same UR process where they looked at, does the diagnosis meet the service definition for day treatment? If the answer is yes, it's yes. Does the service definition meet for outpatient therapy at the same time? Yes, it does. And so on. So we're just now starting to do utilization management as the contract expects us to do.
So really, the bottom line, we have not been watching the hen house.
And not us.
Somebody.
Somebody maybe was not watching the hen house.
But it's been our hen house for 7 months,
But it's been
right?
our
But we
hen
couldn't clinically review these rollovers.
What percent, go ahead. Go
I
ahead.
just wonder, can you quantify for us, as best you can, what that amount of money is that?
Good question.
Can you quantify that? Because I think that's a, you're saying that, but would help us to get an understanding, is that $500,000?
Artie, I think it's more than that in our plan that Charlie's gonna present. We guessed at some of this stuff. What I can tell you is that there were about 5,000 to 7,000 rollover authorizations from both Value Options and Crossroads. And being conservative, if I said that the value of each of those authorizations was only $1,000, you're looking at a couple $1 million.
So just as follow-up to that, if I read correctly the findings in the financial review we received this week, it says that Western Highlands believed they had to honor these authorizations per the transition plan, although they were inconsistent with DMA policy. Did DMA ever offer, did we ask for, did DMA ever tell us we had to honor them and that we shouldn't be reviewing them as required? Looking particularly at PTRF every 30 days versus 6
It's
months.
in the DMA contract that we had to honor authorizations given to us by Value Options and Crossroads.
I'm
Both of
asking
them,
that. Did we ever specifically ask them? Do we?
I did
for
not ask.
policy, or, I mean, because the report basically says we were violating what DMA policy says. It wasn't consistent with policy. So, and that we believe that was the correct thing to do. I just wonder if we ever specifically, beyond believing it, asked them, given you're telling us it's one of the biggest cost overruns we've had.
Because it was in the contract that we had to honor these, we didn't think that we could ask about it. And in fact, when we talked about this in our recent review, they've decided that essentially, Mercer's decided that that was the wrong thing to do. We got to do this a different way with other LMEs coming on.
So basically what we've done is just monitor those services and pay
We
for
could
them?
monitor it. If an authorization from Value Options went out 90 days, we got it on a spreadsheet. It didn't say this person is this kind of sick and this kind of, it just said authorized X service at X duration. We had nothing to look at. There was nothing for us to see. We got spreadsheets
But
that
we
said
were-
enter
we were-
these off.
We were paying for it?
Yes, after January 3rd.
So nobody was watching the hen house.
So-
That's the
so-
bottom line.
Marcia,
Hey, I'm
so
trying to watch
a lot of these kids are in level 4 placements.
PRTF. Actually, there's only about 90 kids in PRTF. We have about 500 kids in residential right now.
Define residential, is that level 2 or level 3?
Therapeutic foster care, level 3, 4, and PRTF.
How many level 3 beds do we have?
Not enough. We've got.
That's what my DSS director told me the other day.
Yeah.
So your big savings is moving kids out of these level 4 facilities, and I think we've got a few of them that are out of state, don't we?
My agenda is to move kids from out of state back into the state, and part of the razor's edge here is that we have to have cost savings to be able to invest in building capacity in other levels of care.
So, in moving forward and fixing our interesting situation, do we have the facilities, the level 3 beds to do that? You know, it's not fun to be a social worker at DSS and have a child that a judge has put into your custody and you don't have anywhere to put them. I've been in that boat before.
Right.
And I understand, I'm following what you're saying about value options and crossroads. And I'm following that we've got 30, 40, 50 kids out of state. We've got kids in very expensive placements. My question is, do we have the placements to step them down to?
I think we do have capacity in therapeutic foster care, but
That's level 2.
That's level 2. A lot of these kids, again,
That's
probably,
a big jump from level 4 to level 2.
actually depends on the diagnosis. There are kids who are inappropriately placed in PRTF for the lock. I got in trouble in a courtroom saying that recently. But a lock is not medically necessary.
But I'll still say it's a big jump from 4 to 2. Somebody
The
thought
state
this.
had the intention of getting rid of all the level 3s. We found some utility for the level 3s.
I know I got a problem with wanting to get rid of the level 3s. I get that level 4 is expensive as all get out. I
It's
got that.
basically extended hospital staff. It's 24-hour nursing, 24-hour access
Right,
to
it's like
psych.
skilled nursing for a kid.
Yes, exactly.
But like I said, if you don't have the next step down, you're in trouble. DSS is in trouble.
The report that we sent the DMA offers some alternatives, and one of the things we want to do is have some evidence-based practice to be embedded in other levels of care. We can do that as we get savings on the PRTF side.
Marcia, not asking you to answer it now, but something I'm interested in from all staff as a board member is what data do you need that you don't have access to now, if any? And I'm not asking you to answer it on the spot, but I think that has to be part of what drives us forward in terms of our plan. So I'd appreciate the thought you gave to that. And then we can do
Okay,
something.
I'll be happy to talk about that. Just informationally, my clinical operations management team is now meeting weekly with the report dashboarding team to try to get, ad hoc data that we need quickly and dashboarding data that we can refresh. So we are working aggressively on that. Part of that gets back to what Don Herring was saying earlier. Our focus at the beginning was to make sure that consumers got taken care of and the providers got paid. And a lot of stuff slid, obviously, for lots of different reasons. But we're working aggressively on that. I'd be happy to give you a report.
Okay, that would help, because I saw in some places you're still very paper dependent, your staff.
Yeah.
Thank you,
Thank you,
Marcia, I
guys.
appreciate it. If there's not any pressing questions, I'm gonna move on to Art.
A couple of questions have been raised about timing, and I thought maybe I could try to go through a scenario of some of the events that occurred here in June. Again, I think we point out that we had a board meeting in June in which we adopted a budget for last year. Prior to that board meeting, and I do believe that prior to that board meeting, staff had begun to identify and review the data that we saw for the end of April. Remember, the end of April data doesn't come in until sometime in the middle of June, being clean, and that we get that information. When we saw that number, we thought, well, this is off. This is not right. I mean, what's going on here? What's our issue? We began to identify that, gather the data, look at these reports, etc. And it looked like, if this is correct, we were going to be running about $500,000 over and a month, and that was the first time we kind of had a sense. We knew that there were issues. We were looking at different kinds of processes within the system. We knew that there was a service stacking. We knew about the PRTF and use. But really our focus was on making sure we got, again, people paid, processing the claims, making sure the network was stable, before we just started, and I guess we didn't want to do any random or impulsive acts that would jeopardize the consumers or the provider network, but really kind of figure out what's going on in here. when we realized that this was clearly a fiscal issue, that we really were not having the funds to cover these costs, that the dollars were now coming in clean for all the authorizations that occurred in January and February and March that didn't come in, as you could see in the spreadsheet that Sharon shared. We had a IMT call, that's the regular monthly meeting that we have with the department to discuss where we are with the waiver on June 27th. And at that meeting, we shared with them, hey, it looks like we've got this overspending. Shared with them this lag report that was provided to the board. And the department said, well, send us that information, send us that report. So we sent the report on up to the department immediately, and they started looking at it. There were concerns. I talked with Mike Watson on the telephone about it. This is a problem. How come we didn't know about this sooner? And I wish we'd have known about it sooner too. We're trying to get a handle on it. We're working on a plan, etc. Received a phone call from Kelly Crosby on July 3rd, who said that they were going to send Mercer out to do a review of our financial situation and what was going on in reference to this information. We had begun with staff after this meeting on the 27th and in between the holiday time to draft a plan to address these Medicaid overspending. We finalized the draft plan on July 10th, sent that to the department, sent it to Mercer. Then on that same date, we sent the lag report, the Medicaid waiver expenditure update was sent to the Finance Committee on July 10th by Sharon to alert the Finance Committee of what was going on. And then later that afternoon, I tried to get out my report, and I sent a CEO report, the lag report, and the draft plan that we had provided to Mercer and to the department on that same date, July 10th. Mercer was then scheduled, and they were here on July 10th to the 12th. On July 17th, the newspaper called, Raleigh newspaper, saying, oh, well, they'd seen this lag report and this draft plan that we'd sent to the department and to the board, and wanted to know what it was all about. I tried to explain that to them, give them the best answers I could at that particular point in time, and sent out communications to the board chair and the board attorney on that same date, and then the next day alerted board members that there could be an article appearing. Weren't sure whether they were going to actually do an article or just was queried or not, but we knew the secretary was coming the next day. So Secretary, is it Delia? Delia was coming the next day. So we wanted the department to have a heads up on that as well. So we called them and let them know that, hey, the newspaper called and asked about this information. We tried to respond, wanted him to be aware before he got here. We knew that the newspaper here was going to talk to him as well after he got here. So he did come on the 18th. We had a phone conference call on July 19th with the department to discuss the draft plan that we had submitted to them on the 10th. They really wanted to try to review it, understand what our ideas were, expand that a little bit more, try to clarify what our rationale were for particular issues, etc. At that point, they decided they were going to take any action or didn't want us to move forward on any of those kinds of things. They wanted to wait for the final Mercer report and to kind of do some rechecking of some figures and issues, because we were talking about the PM and had raised some concerns about that. So they wanted to continue their process. We received the Mercer report on the 24th of July and provided that to the board members and the executive team on the same date. And we are now awaiting a plan of correction from DMA. As of today, we haven't received that, but we anticipate. Mike sent out a letter yesterday. I sent you all copies of his communication. That's the things he would expect that we would be needing to include in our plan of correction. And we'll be waiting for that official document to make sure we cover all of the bases that are in there. The Mercer report process, I must say that we had Mercer out here three times or 4 times before we began the waiver. Charlie, 3? This last visit was really a helpful process. I actually felt like that they were trying to help us find ways to improve upon the system and really address the issues. Prior to that, it was kind of like, are you ready? You need to get this, you need to get this, you need to do these things, etc. But this was really, I felt like that they really kind of identified, at least when they talked to us about issues that we could improve upon, data reports that could be developed and created. It seemed much more collaborative, much more responsive in terms of how we can move forward and what are the things that we're going to do. They were pleased that we had the report in terms of that we thought about and identified some ideas about how to address the shortfall. And I felt like their sense was that, well, with the suggestions that you're looking at